بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we will start the fourth part of the female pelvic imaging, and we'll continue the uh, the discussion about the ovarian and adnexal pathology. Then we have finished by the ovarian cystic lesions, and we mentioned the mature teratoma, the cystadenoma mucinous type, and the serous type. Now we are dealing with one of the rare uh, lesions in the ovary, which is the monodermal teratoma, known as the stroma ovarii, which is made of only mature thyroid tissue. And these lesions represent about 3% of all mature teratomas of the ovary, and they are usually multilocular, and they locules may contain fluid which is of high signal in T1 and T2 due to its colloid content. And also we should know that fat is not seen in these lesions, since fat is one of the diagnostic landmarks of mature ovarian teratoma or the ovarian thyroid cyst. This is an ultrasound examination of the right ovary showing a mass in the ovary which is partly cystic and partly solid. And this lesion was discovered by an isotopic study for the thyroid gland, and it was proved to represent a stroma ovarii. And sometimes this monodermal teratoma or the stroma ovarii may appear, as you see here, almost similar to the thyroid goiter. But these lesions do not usually cause thyrotoxicosis. They may be solid, as you see here, and they may appear hyperdense in the pre-contrast study. And if you inject the contrast material, they will enhance strongly, and you can see easily the matrix calcification, which are usually seen in the thyroid goiter. Then we came to another lesion, which is fibroma or the fibrothecoma. These lesions represent about 3% of all ovarian tumors. They are usually unilateral in most of the cases, and the ovarian fibroma is famous with this syndrome, which is mixed syndrome, formed of the triad, consists of ovarian fibroma, ascites, and the pleural effusion. This is the triad: ascites, pleural effusion, and solid ovarian tumor, which is usually an ovarian fibroma. And it is well known that ascites and the pleural effusion will resolve after resection of this ovarian mass. 90 or 80 to 90% of the masses are of the ovarian fibroma type, but other relatively rare lesions can occur. The pleural fluid is usually on the right side in the majority of cases, and being a fibrous tissue component, it will appear of dark signal on MRI images in T1 and T2 weighted images. This is the uterus, as you know, and this is the ovarian mass, which is of low signal, and T2 weighted images. Sometimes it is almost similar to the fibroid, which is the leiomyoma, and it usually or may contain calcium and undergo some degeneration similar to the fibroid seen in the uterus. Then in 20% of the cases, they are associated with endometrial carcinoma. and 60% of sarcomas have estrogenic activity and may present clinically by uterine bleeding. This is an example of ovarian fibroma by MRI, T1 weighted image, and T2 weighted image, and T1 post contrast. You see the dark signal of the tumor in the T1 and in the T2 weighted images, and it shows some contrast enhancement after uh, injection of gadolinium. And this is another example, and you see a left ovarian mass which is of dark signal in the T1 and T2 weighted images with some faint post-contrast enhancement. This is another example by CT and MRI T2 weighted image. The mass in the CT is solid and of homogeneous CT density. It may contain calcium, as I have said. And here you see the mass in the ovary of dark signal in the T2 weighted image, and this is the uterus. Then we came to the Brunner tumor, which represents about 2% of the ovarian tumors, and this tumor is usually benign, and it is in most of the cases a solid lesion, and it contains calcium, which is considered one of the diagnostic landmarks of this tumor on CT, since you know that MRI is relatively insensitive for the detection of calcium. 20% of Brunner tumors are associated with epithelial neoplasms like ovarian cystadenoma or cystadenocarcinoma. Um, and sometimes Brunner tumors, or many times, the Brunner tumors will display a low signal on T2 weighted image, and they may simulate the ovarian fibroma. And here is an example of a Brunner tumor in the right ovary associated with carcinoma of the cervix, and the epithelial tumor in the left ovary in the form of mucinous cystadenoma. And this is a transabdominal panhysterectomy with bilateral salpingio-oophorectomy sample. And this is a Brunner tumor by CT, solid lesion with internal matrix calcification by MRI. The lesion is of relatively dark signal on T1 and very dark signal on T2 weighted images. Then we came to the ovarian malignancies, and carcinoma accounts for about 4% of cancers and ovarian carcinoma, and these usually most of these tumors are usually silent, and they present at an advanced stage. The ovarian carcinomas are usually seen in the postmenopausal women, and the mean age of presentation is about 59 years of age. The ovarian carcinomas include the epithelial carcinomas, and these also represent about 50% of the lesions, including serous cystadenoma, serous cystadenocarcinoma, mucinous cystadenocarcinoma, endometrioid carcinoma, and clear cell carcinoma. Also, the ovarian malignancies include germ cell tumors and stromal carcinomas. Then the carcinomas are usually suspected whenever you see a tumor that is larger than 4 centimeters in diameter, and this is not an issue because most of the ovarian masses are large. Then you got wall or internal septation thickness, and this is also not an issue, but the most important finding is the presence of a solid component or papillary intracystic projections, and this will turn the benign lesion into a malignant one. Then if you see, and this is a rare presentation, solid mass with central necrosis, and you see some supportive findings for malignancy like the presence of metastatic lymphadenopathy, peritoneal metastases or deposits, and the presence of ascites as well. Then in this lesion, you see a big mass which is predominantly cystic, but there is a solid component, and this solid component will raise, of course, the possibility of being malignant. And the presence of just internal septations is usually seen, as I have said, in mucinous cystadenoma, but the thickness of the internal septations and the presence of mural nodules are important in prediction of the malignant nature of the lesion. And bilaterality of these lesions is common, especially in the serous cystadenocarcinoma. Then you see here an example of bilateral serous cystadenocarcinoma of the ovaries. Both ovaries are involved by masses that are partly cystic and partly solid, and you are able to see some ascites, and you got minimal thickening of the peritoneal covering, and if you look carefully, you can see some peritoneal nodules, which may suspect the possibility of peritoneal metastasis. And this is another example of cystadenocarcinoma, mucinous cystadenocarcinoma of the ovary. And you see big mass, which is predominantly cystic with internal septations and some nodules on the septi and on the wall. And you see these projections inside the cystic component of the tumor. Also, malignant teratomas can occur in the ovary, and they usually contain fat and they contain calcium. And many times you see this lesion relatively big, and it may send metastatic deposits through the peritoneal cavity. As you can see here, there are some metastatic deposits indenting the surface of the liver, and others are related to the spleen and the posterior aspect of the stomach. And you know that the ovarian tumors are one of the commonest lesions that can spread through the peritoneum by metastatic deposits, and this will lead to diffuse or focal peritoneal thickening, and of course, ascites is usually present. And these lesions, if they are large enough, they produce diffuse marked thickening of the omentum, which is known as omental cake in the radiology practice. Then lymphatic spread will go to the external iliac, obturator, common iliac, and para-aortic lymph nodes, while distant metastases may affect the liver, the lung, the pleura, and the kidneys. And this is a frequent finding in the clinical practice, which is known as the omental cake, where you can see a sheet of soft tissue mass infiltrating the greater omentum, lying immediately posterior to the anterior abdominal wall, and the mass is of non-uniform CT density. There are, of course, some linear fat streaks of the omental tissue, and many times, or in most of the cases, then you see a big amount of ascites. This is known as omental cake, and it represents omental deposits, mostly from ovarian malignancies, but this omental cake may also a presentation of metastasis from other intra-abdominal primaries, especially in the colon. And sometimes in some patients, we are confronted by this omental cake, and we go thoroughly through the abdomen or the body. We do not we do not find the primary lesion, and at that time we may go by CT guided or ultrasound guided needle biopsy to have a sample of this omental cake in order to confirm the diagnosis and to know where is the primary malignancy. This is the same. In this case, there is diffuse thickening of the omentum, and there are adnexal mass lesions as well as liver deposits. And the lesions, all these lesions are proved to be metastatic, and there were no gastric primary, which is one of the common lesions that can produce metastatic deposits to the ovary, as I will mention later on. And a good example of omental cake with a very big soft tissue mass behind the anterior abdominal wall, displacing the bowel posteriorly, and in the coronal reconstructed image, it conforms or exactly located in the anatomic site of the greater omentum. Then malignant germ cell tumors represent about 2.5% of the ovarian malignancies, and they are more common in young females. They account for about 65% of ovarian malignancies in the females less than 20 years of age. These lesions are characterized by a very large size, and the tumor in most of the cases is usually solid with rapid growth. Then, in order to diagnose this lesion very simply, you see that the age of the patient is young and the size of the tumor is big. Then you know that you are dealing with one of these malignant germ cell tumors. These tumors include so many names, but the first two are seen in the clinical practice. The rest are extremely rare. The commonly seen are the dysgerminoma and immature teratoma, while the rest of these lesions are extremely rare. Then you remember we have an adult type and a juvenile type. And this adult type represents about 1 to 2% of the ovarian tumors, and in mostly they are the granulosa cell tumors or this germinoma. Then you should remember that these tumors are big and the age of the patient is usually young. Endometrial cancer is associated with these tumors in about 5 to 25% of the cases. The juvenile type usually presents before the age of 30 years, and these are hormonally active lesions may present by signs of precocious pseudopuberty, and the association with Ollier and Maffucci syndrome is known in literature. And as I have said, in order to diagnose the granulosa cell tumors or the dysgerminomas easily, you look for the age of the patient and you look for the size of the tumor. These lesions are usually very big and they occur at a relatively younger age. Then the tumors do not show, sometimes they may show matrix calcification, and there may be some ascites as in this case. Then if you look carefully or you can see the normal uterus, then it's easy to know that this is of course of extrauterine origin. And remember, the age of the patient is young and the tumor is big. Most of the tumors are solid, and some of the tumors may contain cystic changes. And this is one of the rules. A large, predominantly solid ovarian mass in a young woman should raise the suspicion of malignant germ cell tumor. And you see a big mass by CT and big mass by MRI. And this is a female 12 years old with a huge mass pelvic abdominal occupying most of the pelvic and the lower abdominal cavity, compressing the bladder, displacing the uterus posteriorly. then you know that this is of adnexal origin, and the diagnosis of this germinoma is easy. And sometimes if you can see fat, and also you may see foci of calcium, this is fat which is darker than fluid, and some foci of calcium, then you know, or you may suspect that this is immature teratoma. Then you should know that ovarian lymphoma, primary ovarian lymphoma, is extremely rare, and lymphoma of the ovaries, lymphoma of the uterus, is usually secondary to lymphoma elsewhere in the body. And in order to diagnose lymphoma of the ovaries, for example, or of the uterus, then you should know from the clinical picture of the patient that the patient had lymphoma elsewhere in the body, or you can see the stigmata of lymphoma in the scan. And if you remember, I said that one of the suggestive criteria of lymphoma is the presence of bulky, homogeneous, amalgamated lymph nodes. And in this case, it is easy to see the bulky, homogeneous, amalgamated lymph nodes surrounding the aorta, and to see a big mass involving the uterine colpus as well as the uterine cervix and the adnexal region. And this is an ovarian and uterine lymphoma. Metastases to the ovaries account for 10% of the malignant ovarian tumors. They are usually of gastrointestinal origin sometimes, but melanoma, endometrial carcinoma, pancreatic, gallbladder, gastric carcinomas may produce this type of metastasis, and bilateral involvement is typical in about 3/4 of the cases. About 50% are Krukenberg tumors from the stomach or gastrointestinal origin or from the breast cancers. And most of the ovarian metastases are usually asymptomatic, but the presence of ascites and big masses may produce some compressive symptoms. The distinction between a primary and metastatic ovarian cancer is not possible, but if you see bilateral, sharply defined, mainly solid ovarian masses, and this will strongly favor the diagnosis of metastatic metastatic deposits to the ovary, and is usually of the Krukenberg type coming from the stomach or the breast. Then here you see this patient with a colorectal cancer, and you see solid mass in the left adnexal area, and this is a Krukenberg metastatic deposit. And this patient, 34 years old, having a gastric tumor. You see the stomach, there is diffuse gastric mural thickening encroaching on the gastric lumen that was proved to be a cancerous stomach. And in the pelvis, you see a mass which is partly cystic and partly solid in the left ovary, diagnostic of ovarian Krukenberg tumor. You can also easily see the presence of ascites. And this is the classic appearance of Krukenberg tumor, bilateral ovarian masses, and these masses are almost solid. They show intermediate signal in the T1 and also intermediate signal in the T2 with evident post-contrast enhancement, and you see the presence of ascites, and the patient is known to have gastric cancer. Then in this case, you can see that there is a right hemicolectomy. The right-sided colon is not present. And in the pelvis, you see a big mass, which is predominantly solid in the right adnexal lesion. You can also see minimal amount of ascites, and this is the Krukenberg tumor from colonic cancer. Then we have some words about the fallopian tube. You know the fallopian tube Length ranges from 7 to 16 centimeter. The average is about 12 centimeter. It is divided into four parts. The intramural part inside the wall of the uterus, which is in the range of 1 to 2 centimeter. The isthmic portion, which is the second segment, measuring about 2 to 3 centimeter. Then the ambulatory portion, which is the largest one or the longest one, measuring about 5 to 8 centimeter. Then the infundibulum, and which is closely related to the ovary. Lesions affecting the fallopian tubes include salpingitis ethnica nodosa, hydrosalpinx, tube ovarian abscesses, ovarian torsion, and ectopic malignancy. The salpingitis ethnica nodosa is an inflammatory process of the fallopian tube of unknown etiology, usually seen in the course of pelvic inflammatory disease, and this lesion will appear as multiple small contrast-filled divertically along the course of the fallopian tube. And this is the hysterosalpingogram, of course, and this is the only way, in my opinion, to see this salpingitis ethnica nodosa. Then, a second lesion affecting the tubes is the hydrosalpinx, and this is the histogram showing normal appearance of the uterus with dilated, markedly dilated distal part of the fallopian tubes retaining the contrast, and you see the stagnation of contrast material with no spill within the pelvic peritoneal cavity. Then the tubal obstruction of the fimbrial part will result in retention of the secretions within the tubes, and this is usually the sequelae of pelvic inflammatory disease. Hydrosalpinx can be diagnosed by MRI, and this is an axial T2 fat sac. You see the fallopian tube, which is dilated along its whole course, and this is another one on the right side containing fluid, which is of bright signal on the T2 weighted images. Of course, you need some other sections to be sure that this belongs to the fallopian tube, not to the ovary. And if you see this tubular-like structure, you know that you are dealing with the fallopian tube, not the ovary, of course. And this patient had the bicornuate uterus, which is filled of high signal material or blood, high signal blood, in the T1 weighted image, and in the T2 weighted image, this is blood, and the fallopian tubes are also dilated and filled by blood signal, which is bright in the T1 and bright in the T2 weighted image. And this is suspected to be due to the presence of a transverse vaginal septum that prevented the blood of the menstrual period to come out, and it is retained in the uterus as well as in the tubes. Then, and tube ovarian abscess is like uh, any abscess anywhere in the body. The abscess is a cystic, hypodense, marginally enhancing lesion, which may contain internal septations denoting multiple loculation. This may affect one ovary or may affect both ovaries. And one of the complications of intrauterine contraceptive devices is the ovarian abscesses due to actinomycosis, according to the literature. Then the abscess may produce local inflammation and may produce local peritonitis. The tubovarian abscesses are not usually seen in the postmenopausal woman, and in such cases, these patients are usually diabetics or have a prior history of pelvic irradiation. And this is a 25 years old female with 2 weeks fever, pelvic abdominal pain and tenderness, and you see bilateral ovarian abscesses having the typical configuration of the abscess, cystic fluid containing lesion with marginal enhancement. The margin is of uniform thickness. There may be internal loculation, as you can see here, and this is bilateral tubo-ovarian abscesses. Abscesses may be unilateral, may be bilateral, and of course, one of the stigmata of abscesses is the presence of air or air fluid level, but unfortunately, this sign is usually uncommon in almost all abscesses all over the body. Then stranding of the pelvic fat planes is usually found due to the inflammatory reaction of the fat around the ovaries. Then TB ovarian abscesses or TB tubo ovarian abscesses are usually associated with large amount of ascites according to the literature. In areas, you see some ascitic fluid in the Douglas pouch. And ectopic pregnancy means that the pregnancy is occurring outside the uterine cavity. 95% occurs in the fallopian tube. 3% occurs in the ovary itself. 2% occurs in the peritoneal cavity, and about 45% of these patients they have a pelvic inflammatory disease or chronic inflammation of the fallopian tubes that hinders the passage of the ovary, and it rests anywhere along its course, resulting in this ectopic pregnancy. Then the imaging findings, ectopic pregnancy is usually diagnosed by ultrasound, but if you have a CTO or MRI, you can see that the wall of the tube is thickened and enhanced, and you got fresh blood within the fallopian tube, and you may see an adnexal mass and sometimes intraperitoneal bleeding, meaning that this pregnancy has been ruptured. And this is just an example showing a lesion which is intimately related to the myometrium, and you see some extension of the myometrium along the edge of the lesion, and it appears of a bright signal in this T2 weighted image, and this was proved to be a gestational sac of an ectopic pregnancy. And torsion of the ovary means that the pedicle or the pedicle of the ovary has torsed, and there is some compromise of the blood supply of the torsed ovary, and here are the predisposing factors. In most of the cases, there is a benign tumor, which is usually a dermoid cyst, and sometimes the adnexa is hypermobile or elongated fallopian tube, or many times, or sometimes also you can see increased intra-abdominal pressure, and about 20% of ovarian torsion may occur during pregnancy. Then malignant tumors do not tend to undergo torsion, of course, because of the invasion and infiltration of the surrounding, making the ovary immobile. Then the right ovary is a common site for torsion, and this is suggested by the literature that the sigmoid colon may have a role in preventing torsion of the left ovary. Then torsion is usually seen in a young woman, and the clinical presentation is usually acute pain and vomiting. And sometimes the torsed ovary is seen in the midline above the uterus. And if you inject contrast media, you will got some perfusion defect of the affected ovary. The ovary is usually of bright signal in the T1 and T2 weighted image because the presence of internal hemorrhage. and sometimes you can see the benign tumor that is the precursor or the factor leading to torsion of the ovary. Then this is ovarian torsion by CT and by MRI T2 weighted image. And you know that because of the edema and the ischemia, you got the swelling of the ovary itself. And if you inject the contrast medium, you will see no enhancement because of the compromise of the blood supply. This is the towards the ovary in the T1 fat suppressed image, and this is T2, and this is T1 post contrast. You see enhancement of the uterus, but you don't see enhancement of the ovary. And this cystic lesion posterior to the ovary represents the dilated fallopian tube. Then these are some of the important notes for the diagnosis of ovarian torsion. The, the age for ovarian torsion is around 10 years, and half of the cases occur in the premenstrual period, and 20% of the cases may occur in the neonatal period. Then the blood flow, normal blood flow, does not exclude torsion. And you know that torsion may not compromise the blood flow significantly so that you can see it on imaging. And then if you see an ovarian volume which is more than 100 milliliter, and this is highly suggestive of torsion. An ovarian volume less than 20 milliliter in the postpubertal female is never torsid ovary. And comparing the size or the volume of both ovaries, if you see the discrepancy more than 5 times, and this will suggest the torsion. Then we came to the pelvic congestion syndrome, which means that there are abnormally dilated veins in the pelvis, and sometimes they refer to this syndrome as the equivalent to the testicular varicocele in males. The symptoms are usually in the form of chronic, dull pelvic pain, pressure and heaviness, dyspareunia, dysmenorrhea, and postcoital ache. Then the incompetent ovarian veins will lead to retrograde flow of the blood into the pelvic veins, which are the veins in the broad ligament, the ovarian plexus, the pelvic side walls, the paravaginal plexus, and the vulval veins, as well as into the extremities maybe. And these lesions are associated with polycystic ovaries in about 40% of the cases. Then some of the leading causes is the presence of retroaortic left renal vein, and this may hinder the flow through the vein, leading to retrograde flow in the ovarian vein. Also, the presence of the right common iliac vein compressing the ovarian vein on the right side may lead to pelvic congestion, and the treatment of choice is, of course, by embolization of these dilated veins. And in order to diagnose pelvic congestion syndrome, there should be at least 4 ipsilateral dilated veins of varying calibers, at least one vein larger than 4 millimeter, and the ovarian vein diameter is more than 8 millimeter. And here you see the ovarian vein is dilated, and you see some dilated tortuous veins in the pelvis. And in this example, you got enormous dilatation of the pelvic veins on both sides, and also you got dilatation, marked dilatation of the ovarian veins. And this is another example. You see dilated veins. This many times seen in the clinical practice, and I didn't find an explanation actually for this appearance before I know that this is the pelvic congestion syndrome, and you know that many of these patients are usually asymptomatic. Then this is pelvic congestion syndrome with dilated tortuous veins by this CT contrast enhanced CT contrast enhanced image, and this is by the retrograde venogram. This is by MRI, coronal post-contrast MR image showing the retrograde flow in the left ovarian vein with dilated collaterals in the pelvis. Then we came to the last issue, which is the vagina, and this is a fibromuscular tube, which is about 8 to 12 centimeter long, and it connects the uterus to the external environment, and it has a high T2 signal mucosal layer and a low signal intensity muscular wall. And many times, whenever we are evaluating this particular area, including the cervix and vaginal pathology, we usually need to insert a vaginal tampon or to introduce the ultrasound gel in the vagina to distend the lumen so that we are able to see any pathologic abnormality. And these are the expected abnormalities or the congenital lesions: agenesis of the vagina, duplication, vaginal septum, rudimentary vagina is associated usually with uterine hypoplasia, and vaginal agenesis may be associated with renal agenesis or ectopic kidneys. And you remember we mentioned that whenever you're examining this area, you should have some scans for the abdomen looking for renal abnormalities. And one of the common findings that is considered an incidental finding is the Bartholin cyst, which is a retention cyst in the vulvovaginal glands, in the ducts of the vulvovaginal glands. And these symptoms do not usually cause symptoms unless they are large and they produce some uncomfortable sensation while walking and sitting. Then these cysts contain fluid which is dark in the T1 and bright in the T2 and may got infected, leading to the formation of an abscess. Then they will enhance marginally after injection of contrast. In cases of imporphyrotimin or vaginal atresia or transverse vaginal septum, the menstrual blood will be retained, leading to massive distension of the vagina, and sometimes this may extend also or reflected on the uterine cavity, which is seen here containing some blood, and also, as you see in the previous case, the fallopian tubes may be also affected. Then this is the sequelae of one of the lesions that prevent the menstrual flow to go outside the body. This purple arrow points to a porcelain cyst in the vagina. And this is an example of a case with vaginal atresia and the hematocolpos. You see, this is the vagina, which is hugely distended by blood, and this blood is bright in the T1 and T2 weighted image. You see the fluid in the bladder is black here and bright here, and if you look carefully, you see the uterus is minimally distended, containing some blood as well. Then a skinny duct cyst is a retention cyst in the paraurethral ducts. And this cyst may be mistaken for the Bartholin cyst, and it usually shows the same criteria, being low signal in the T1 and high signal in the T2. And most of these cysts are usually located below the symphysis pubes. then they should be differentiated from Bartholin gland cyst, which is usually somewhat difficult, and also from urethral diverticulum. And urethral diverticulum is almost never asymptomatic, but the skinny duct cyst and Bartholin cyst are usually asymptomatic. Finally, the vaginal carcinoma is rare and it represents about 1 to 2% of the malignant tumors of the female genital tract, and the age of incidence is about 50 to 70 years. Most of these tumors are of the squamous cell type. Other malignancies can occur in the vagina, like the sarcomas, as leiomyosarcoma and fibrosarcoma. Then these lesions, the carcinomas, usually have invasion of the surrounding structures, especially the rectum and the bladder-producing fistula tracts. And this is a case of vaginal carcinoma developed after previous hysterectomy for a benign disease. In the T2 weighted image, you see an intermediate signal lesion, and also in the T1, if you inject contrast, the lesion will show some enhancement. And vaginal carcinoma usually spread directly to the pelvic adjacent pelvic structures or proximally to the uterine cervix, distally to the vulva, and they also may spread by hematogenous route, giving metastases somewhere in the body, and this is rare, and they may affect the liver, the lung, or the bones. The staging of vaginal cancer is easy, since if you see a lesion which is confined to the vagina, and this is stage 1, if the tumor involves the paravaginal tissue but did not reach the pelvic side wall like this, and this is stage 2. If the tumor has reached the pelvic side wall, and this is stage 3. If it has invaded the urinary bladder or the rectum, and this is stage 4. Embryonal rhabdomyosarcoma is considered the commonest type of genital rhabdomyosarcoma, and it presents mainly in infancy by huge mass located in the vagina and the vulva and the perineum. It is easily differentiated from sacrococcygeal teratoma, since the teratoma has its diagnostic landmarks, and this rhabdomyosarcoma has a good response to chemotherapy with better prognosis. Thank you very much. Alhamdulillahi Rabbil Alameen.